Well, hey everybody. My name is Garrett Schmidt. I am the CEO and managing editor for VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by TopCon Healthcare. And today's session is called Real World Applications of AI, Retinal Health Screening. We're going to be talking about healthcare from the eye. And very excited about this topic, and I'm serious about that. I got in a conversation with these guys, and this is such interesting stuff. So I think you're really going to enjoy this presentation today. A few items of housekeeping before we get started here. Everyone has joined today in listen-only mode, so this is a traditional webinar format. You don't need to worry about muting your microphone or turning off your camera or anything like that. We can't see you or hear you. However, we do want to hear from you, and we're going to have a time for some Q&A towards the end. And if you have a question at all for either of our speakers, at any point, drop that question into, there's a little module that you have as an attendee, and there's a question place in there. So go ahead and put your question in there. And if for some reason we don't get to yours or we run out of time, whatever, don't worry about that. Someone will reach out via email afterwards and make sure that we get your question answered. Finally, this session is being recorded today, and so what's going to happen is when we're done, about an hour or so after the conclusion, you'll receive an email from our team, and there'll be a link to the recording as well as to where you can download the slides today, and there'll be some other information there as well. So I hope that you will watch it again if you would like, or share it with colleagues. You can certainly do that. Without further ado, wanted to introduce our speakers today. First of all, we have Dr. Matt Rosenberg, and he is the medical director and managing partner, rather, of Mid-Michigan Health Centers. And we also have, and they'll give a little introduction more of themselves too, is Mr. John Bartolovich, and he's a healthcare economics and reimbursement manager at TopCon. And these will be your guides today. So welcome, gentlemen.
Thank you.
Derek, thank you for having me. John, always good to see you.
Yeah, absolutely. Thanks everybody for joining us. I am going to drop off camera so that if any of my annoying habits show up, they don't bother any of you.
Uh-oh.
But I did want to, first of all, thank Dr. Rosenberg for this. I've been working with him for about 4 months now, and it's been a pleasure working with Dr. Rosenberg on this project. As was mentioned, he is the managing partner of Mid-Michigan Health Centers. He has almost 30 years experience as the medical director at Mid-Michigan. He's formerly been the chief of family medicine at Henry Ford Hospital located in Michigan. Originally started out, and this was interesting for me to see this or know this, as a urologist, and actually pioneered research in and on painful bladder syndrome. So great to have you here for this discussion. And the one thing I will say, his office is adorned with family photos. It's amazing, and he has every right to be proud of that family. So.
Oh, they're very kind. Although my kids get embarrassed when they come in the office. Well, they used to when they were little. Now they come in and they'll bring their friends because I've got cute little pictures of my daughter and my son, although, again, a little embarrassing now. But it makes me laugh.
Myself,
Yeah.
yeah, and I've met his family as well, so and they're great to be around. Myself, as Garrett said, I'm the manager of healthcare economics and reimbursements at TopCon Healthcare. Uh, Disregard the typo on the slide. I've been in diabetic imaging for about 13 plus years. I do have 30 years of experience helping medical professionals with innovative products and ideas. And one of the things I'm most proud of, as Dr. Rosenberg is proud of his family, I am proud of the fact that I am the father of 24-year-old twin daughters and 23-year-old, oh, sorry, 25-year-old twin daughters and 24-year-old twin sons. So, but enough of that. Let's get on to what we're here to talk about. Um, we're really going to talk about healthcare from the eye today, what that means, uh, compliance issues when it comes to diabetic retinopathy, in the changing landscape, but more importantly, how AI, uh, artificial intelligence, is helping to close care gaps for diabetic retinopathy screening. And then we're going to talk about how this has worked in Dr. Rosenberg's practice. So with that, Garrett, we do have a poll question.
All
And that
right.
question is your practice or health plan currently performing the diabetic eye screening in office? A,
Okay.
yes.
Yeah.
B, no. C, we were, but.
So you all will see that on your screen now, and of course this is we're going to have another one of these towards the end, and this is completely anonymous. So, but we're going to show the results so you can see where you stand among your colleagues, and we've still got a number of results coming in here. So we'll give it a few more seconds for pretty straightforward questions. So hopefully not too complicated. I think most of the results have come in, so I'm going to close it down in 5, 4, 3, 2, and 1, and I'm going to share the results with you here. Ooh, got a couple last minute entries. There we go. Okay. Are you guys able to see these results? John, you may not be able to since you're
I
sharing the
cannot.
screen.
So
Okay. So we've got 50% says yes, 45% says no, and 5% says we were, but
well, those are interesting results, and it's good to see so many offices that either have or are currently performing the diabetic eye exam in office. I think we've got some things today that may change how you view that, and let's move on.
Actually, John, can I ask a question on that?
Absolutely.
So let's go back to that slide, Garrett. I don't know if you can do this from a technical standpoint, but I would love to know what if I could ask what people are using.
oh.
Would that be
Well, I'll
possible?
tell you what, if you want to drop that answer into the chat, or I could create a question that, real quick on the back end that we could use later.
Oh, I'll watch the chat for a minute because that'll help me as we discuss this.
Sure.
If the people looking at this, and I don't I don't know where to put up chat, but I would love to know if they're using what are they using for screening devices. So if they can put that in, that would be fantastic.
Good question. Yeah, so if you want to drop that in the chat, you should have an area on your attendee module to do that, and then we'll monitor that as we go along.
So I'm going to send a message if everyone can look at it. I'm going to say, what type of device, type of screening device are you going to use? Are you using?
I'm going to make sure that you send that out to everyone.
You using. Okay. And it is sent.
Great.
So I'll watch that as we go forward. And there's a bonus prize to the first person who answers.
That was good.
A picture of one of John's kids.
Yeah.
Oh, they
Only
come in
one.
pairs.
Yeah.
You get half of one.
So a little bit about TopCon as we move on and the direction we're going. TopCon has been in eye healthcare for 90 plus years. If you've been to an ophthalmologist or an optometrist, you have probably seen or been tested on a piece of TopCon equipment. We have slowly moved towards and now are officially calling it healthcare from the eye. And we look at this as a way to help primary care and eye care coordinate together for disease states that you may or may not think of when you think of eye care and images of the eye. Um, so we have three processes here. There's an equipment end, there's an infrastructure end, and there is the AI. So let's start with there are multiple AIs out there right now that can be utilized for diabetic retinopathy screening. We have partnerships with all three of those. But today we're going to talk about one of our partners, AI Health, that's AEYE Health, they are the only AI solution out there right now that can be utilized on both a desktop or a handheld device. It's one image per eye. You get results in 10 to 30 seconds. And again, as I said, it is currently the only solution that you can use on both a handheld or a robotic desk camera. One of our other partners, and it's key here, is Microsoft. And the TopCon, Microsoft, and the AI partnership, we are able to now give you everything you need to deliver eye care from the eye. And by that, TopCon is going to provide you with both may or may not provide you with a camera, but we are going to provide you with our Harmony software package, which is really the delivery mechanism for AIs and AI health. And it's going to enable other AI partners to deliver their solutions without disrupting workflows, but really enhancing the workflows in the office. And also without worrying about security or patient privacy, but to focus on the disease biomarkers they're targeting. And the reason for that is the power of the Microsoft infrastructure that we're partnering with. So when we talk about healthcare from the eye, more and more we're looking at other things. I like to always quote Dr. Eric Topol, who in a famous TED Talk made the comment that we are fast approaching a time that when we go to see our primary care physicians, one of the first things during that physical exam or checkup is going to be fundus imaging of the eye. And the reason for that is it's one of the few places that you can look at the brain and what's going on with comorbidities based upon changes in the eye. So you look at this, and some of the things that we see going on out there in the marketplace are diabetes screening, cardiovascular screening tests that need to be done, neurological testing, and other eye diseases. So glaucoma, AMD, things of that nature. We see eye healthcare from the eye by being able to take these modalities via the image of the eye on a robotic, rapidly accessible eye exam and come up with risk score calculators, health risk score calculators. So that's really where we see this moving. And our first foray into this is with diabetic retinopathy exams. But know that there is more coming down the road. There are companies out there working on biological age, glaucoma, Parkinson's disease, cardiovascular disease, kidney function, and all other eye diseases that are out there. So currently, we do a lot of screening in primary care and in the healthcare system. Costs about $3,000 per patient. These are just some of the screening tests that are done in a facility, in a practice. So, Dr. Rosenberg, does this look accurate? Does this look like what's going on in your practice?
Kind of yes and no. It's a good example, certainly with the diabetes. That's what we're talking about today for the diabetic retinopathy. Excuse me. The diabetic screening we do, the cardiovascular evaluations and screenings we do. In regards to the neurologic diseases, really interesting there because there's a lot of work going on. We should be screening for this more. There's actually, if people follow what the government's pushing with the healthcare acts, they're really promoting us to be screening much better. Screening is tough. Diagnostics aren't readily available, so that's few and far between. The eye diseases, again, for those of you who are doing any sort of Medicare, as you know, we're supposed to be making sure they have glaucoma checks. So yes, we're doing that. That's a new Medicare push. But I do want to emphasize, John, that screening is good. We should be screening. I mean, we want to screen. If any of you are all involved in research, we do screening if it makes a difference. If screening doesn't make a difference and it just costs money, then that's not a good idea. But if screening is done and it changes the trajectory, and in the cases that you've listed here, this is where screening is good, because if we catch something early, we prevent the bad outcomes later. So that's really how we want to be pushing this. So this is consistent with the screening modalities or the screening environment that we see now, maybe with the exception of neurologic disease. But it's really interesting, again, what we're here talking about today with the diabetic retinopathy and why that's so important.
Fantastic. So with that, let's talk about how the use of AI has been at your primary care facility for closing diabetic retinopathy screening
Yeah,
gaps.
no, thank you. And let me start with this. John, when you gave my bio, we were talking about more of the pictures on my walls, but and my research in bladder issues. So here it's kind of funny for people paying attention to it. Here I'm a family doctor. I've done research in bladder stuff, but the bladder is generally pretty far from the eye. A couple feet actually. I'm not an eye specialist. I'm by far not that. I'm actually, my first life, I'm trained as a urologist. And then in my final year of urology, I realized I didn't want to do that. I wanted to go back into primary care, which was my ultimate goal in medicine. And I've been practicing primary care for 30 plus years. Um, in addition to that, I had my leadership positions at the hospital. I'm now as well as the chief medical officer for ACO, large ACO based in Tennessee, although we're all over the country. We've got a couple thousand physicians, a bunch of lives. So I do a lot of things, but no, I'm not an eye specialist. So how did I get involved in this? And that's an important thing to answer to show where we started to where we are. So as part of my role, I look at, as a CMO, as Chief Medical Officer, again, of quality and strategy for a large group, I look at my quality metrics. I've got thousands of physicians. I got to keep up on screenings when they're appropriate and the tests when appropriate. And one of the things that's been on my radar has been retinal screening. And, as you see here from the top slide, less than 50% of Americans with diabetes are tested for a diabetic retinopathy. Actually, there's some studies that say 85% are not screened, which means we only screen about 15%. I know with our group, as I was looking at our group's data, so just our group, we were about 51%, which is bad. And that's, so why are we so low? Now, as people listening in the audience, you'll know if you're in primary care, getting people to screen is tough. Getting it done in the office is great if you can do it. Certainly, most providers have not been able to screen for diabetic retinopathy in the office, although the numbers that y'all showed me were a little higher. So which means we have to send a patient to an optometrist or an ophthalmologist, which is a problem. That's horrible, because you're going to send them out of the office, schedule an appointment. You're going to hope they go. You're going to hope they find somebody. And the reality is the screening modality, the screen doesn't take place. So years ago, we actually tackled that in our office by trying to get a handheld device that we would ship off, but I'll talk about that I'll talk about it a little later. When you look at the compliance data, one of the things I found out, again, my role as CMO, a lot of patients with diabetics have a diabetic retinopathy, and some of them have vision-threatening issues with this. We know if we catch it early, we have a good shot at taking care of this. You saw that fourth point, 90% of diabetes-related vision loss can be avoided. But again, we go back down to low compliance. So got all this data, put on my CMO hat, and I'm like, what am I going to do? And I didn't have an answer. I was looking in the literature. I had seen the stuff on AI, and I was certainly very interested in that, but I didn't really have a place to tackle it. And as it ended up, John, as you spoke, we've known each other for a couple months. I was giving a lecture at the American College of Physicians. God, when was that? I think it was April or May, John.
April.
And they had this latte booth, which was really good. They used a computer to make a face of your face on a latte. It was kind of cool. So everyone's standing in line. I'm about to give a lecture, and I figured I needed some more caffeine. So I stopped by there, and right across from there is John. And John. There was a second John there. And I'm looking at this, I'm like, the AI retina stuff, I had just read about this. I hadn't seen it. So I said, look, I don't have time to talk, but give me your card. I'm going to take a look at this. And I went home and I looked it up, and I'm like, you know what? I've got a compliance issue, and this group might have an answer for me. So I went ahead and we had a phone call, and we decided, how can we make this work in a primary care setting? Can you go to the next slide, please, Sean? Oh, great. There we go. So we thought about the challenges, and this is what I was talking about, John. I mean, we've got, what are my challenges for screening for anything? If it's labor intensive, that's not good. If it's a complex device, that's not good. If it interrupts my workflow, it's not good. If it's prone to errors, that's not good. Do I get a delayed response? Well, the reason I was asking about this, I actually had the handheld camera that you take a picture and you ship it off to an ophthalmologist, and the delayed responses were horrible. Most of them weren't working, and it just wasn't easy. And that actually goes along with the next point: extensive device training required. That was kind of tough, and so getting patients to follow up, closing the healthcare gaps, these were all problems. So this was the problem I had in the existing model, that I was trying to do it myself. Now, a lot of my colleagues, I mean, this is a very advanced group because about 50% were doing it, but a lot of my colleagues, most of my colleagues weren't doing it. I would have expected that number to be about 10% were doing it in the office, but most of my colleagues were not. So what I told the Johns, I'm referring to two Johns now, so I'll use Johns. Go to the next slide, please. Was, if this is going to work, what I need something to, again, I'm not a retina guy, I'm not an eye doc, I'm a family doc. I need something that is going to be easy, is going to be quick, is going to give me an answer. It can't take up a lot of space, it can't take up a lot of time. I mean, I am just like all of us. We're seeing a lot of patients, and I'd love to have a billion staff members, can't afford it, but if I take up too much time on a staff member, that's not going to work well, right? So the question is, can it with your device, and we're talking about the AI device now, is this functional in office? Is it going to be easy to do, not take up a lot of space, easy for my nurses, in point of care, so improve my patient outcomes, improve disease management by catching it early, and close healthcare gaps. So that's what we were looking at. All right. But I was also looking at, okay, you can go to that next slide. It's fine. But I was also looking at, is it feasible? Now, go back one slide, John. I'm sorry. But because of our computers here, John is doing all the slides. So, um, but I was also looking at, I mean, these things can work, but is it going to be too expensive for me to use? I mean, in primary care, I would love to say we have a lot of the resources that hospitals might have, or larger systems. We don't. But is it going to work? So as you go to the next slide, what I did was I said to the Johns, I said, let's do this. Let's try this out. I'm going to test this out. You're going to bring it to the office. And John, very nicely came and brought the machine and trained my nurses. I said, first step is, can you train my nurses on this? Are they going to be happy with it? Because they've already been a little bit negative on the handheld device. Is it going to take a lot of time? Is it going to take up too much space? Is it going to be easy for the patients, or is it going to scare them off or hurt them? And the final thing I looked at is it reimbursable? Because I can do every test in the world, but if it's not reimbursable, I drive my practice into the ground. So this was the data that we looked at right here. And if you look at the second point there, duration of study, third point, sorry, between May 6th and August 2nd, we did, so for those 3 months, I looked at patients. So anybody who is a diabetic, I actually screened them. So the successful screens were about 207. We actually attempted 215, but 8 of my patients, I will tell you, all of them had cataracts. Those 8 we weren't able to do, but 207 we were able to do. And this was a retrospective chart review. We looked at, if you see the patient ranges there, 23 to 95. You see a few more men than women. You see the ethnic distribution, the type of insurance distribution, and the type of diabetes. So that's what we looked at. So let's look at the data on the next slide. Okay, so really some interesting things. And to be honest, we were getting pretty excited right away. And I actually, day one, and I will share this with you, before we really got into this, my lead nurse comes out and said, this is so easy. And then she goes, can I take that handheld device and throw it away? Because I don't want to use it anymore. I said, well, let's hold on for a minute because it was expensive. But she goes, this is easy. This is taking us, she goes, within a day, it was taking them less than 2 minutes. Because as John pointed out, the machine does the work for you, does the read for you, prints out a piece of paper. You're either good or you're not good. So when we look at this, we did 207 patients in 3 months, as opposed to in all of 2023, I did 98 patients. Now, to be honest, I did not know we did so few patients. When I was asking my nursing staff before this process started, I said, well, what's the deal? They said, well, that machine, the handheld, is hard to use. So when we can do it, we do it. But most of the time, we actually can't do it. And if we're busy, it's going to take us 15, 20 minutes. We can't do it. We don't have that kind of time. So in 3 months, I more than doubled how many patients I did in the prior year. It took less than 2 minutes. It doesn't take a lot of space. It's in one of my multiple use rooms, so I just push it out there, wheel it out. The patients take care of it. We're assuming that we're going to get to a compliance rate of about 96%. Now, last year we were at 51% because I had patients who went, some of them would go to an optometrist or an ophthalmologist. So that 98 that we did last year was not fully that 51%, but we're anticipating a 96% compliance. That's my goal for my staff. And I think we can do it because if you're a diabetic, we get you the day you come in, boom, it's point of care, lickety split. So we identified of the 207 patients, 13.5% or 28 patients were identified as positive for having more than a mild diabetic retinopathy. The interesting thing with that, this is an example of that, but I give them a piece of paper. I show them their retina on the paper. I say, this is the problem. This is why I'm referring you over. So now the patient's empowered. They know they're getting a referral because we have an issue they want to take care of. So they're motivated to do it. This is more than just screening. So that was key. So that patient compliance issue went up. Because before they're like, diabetic retinopathy, Dr. Rosenberg, you're just testing everything. Now they get it and they know why I'm doing it. And the final component that we looked at, and this probably is what made the Johns nervous, but we looked at the reimbursement. Because I could have the best test in the world. If I can't reimburse for it, then I can't pay John and for the machine, and that's going to be a problem. We looked at the reimbursement, as you see here. It ranged from just under 65, 26, 20 for Medicaid, 37, a little over that for Medicare. So it's like everything in medicine. Nothing pays a huge amount, but if it pays enough for me to be able to afford to do it, that's good. So let's go back now on the next slide. Okay, let's look at what I've learned on this. All right, because I set out, was this going to be easy to use? Yes. Did it save both staff and patient time? Absolutely, because what we were doing before was a handheld camera that took 15 to 20 minutes. So we saved a lot of time. My efficiency went up. That was clear. It helped me with point of care. I think we all know this is generic for anything. If we can do a test point of care, the chance we're going to get it. If the patient's there and we do it, it's done. If we have to say, well, you're going to go to the hospital or this diagnostic center to get this test, some of them will go, others won't. All right. There's a nice referral system where we can get the scans over to the retinal specialist when we need to. And again, the nice thing that we figured out was that now the patient's empowered and they'll say, hey, I didn't know this was happening. This is important. Let me get to that eye doctor right away because I want to take care of this. So we've empowered the patient. And we do, that's kind of our roles in medicine. One of my attendings told me this years ago. We have that debt to the patient: diagnose the problem, educate them to the disease, and then treat it. And this really falls in line with that. We're diagnosing the problem. We're explaining to them by showing them. And that's going to empower them and motivate them to get the treatment. And the other thing what I learned here is it doesn't take, not only does it not take a lot of time, it doesn't take a lot of space. And the reimbursement is what it is, but it is something that is reasonable and financially, at least it's affordable within what we do, because all those parameters had to be met. Next slide. And this is just kind of reviewing what we just spoke about. This, again, I can't emphasize enough that point of care is so important. 30 years ago when I set out in primary care, and this is probably some of my surgical background, we try to do everything in our office. Patients are comfortable with us. They trust their primary care doctor. Remember, in primary care, the commodity is trust. They trust us more than anybody. That's why they come here. So that point of getting it for them, they're happy. It increases our access to that health if we look at it through the eye or vision care, because at least we know they're getting it because the compliance numbers go up. and that disease management's easier. Now, for a lot of us in ACOs, again, my company is an ACO, or the company I'm a CMO for, getting our HEDIS scores up is good. Medicare is happy with that, and it actually helps us with reimbursement and the quality bonuses that we've seen. There's another perspective of this that John has mentioned, which I think is important, is when we look at the numbers of optometrists and ophthalmologists able to do this, which are not a lot, right? When we can have something like this readily usable, then we're going to enhance that support for places that can't get it, whether it's underserved communities in the United States. But one of the things I was sharing with John when we first met, this would be a wonderful device outside of the U.S. as well. If we can just do these things automated with that. With the point of care testing, obviously that reduces travel time, which is huge as well. And I think the key point there is point of care is better. And the final note about the economic burden, you saw the reimbursement for that test, $30, $60. A referral to an optometrist or an ophthalmologist is a heck of a lot more expensive than that. So actually, by doing this, if we're in a value-based care program, it certainly helps us a great deal. Next slide, please, John. So what I did in my here, because I have a large group that I represent, I'm the CMO. I have a medical directorship below me, or that I don't say reports to me, but I work with, and then we report out to everybody. So phase one or pilot one was to test it in my office. When it worked, I got my medical directors to try it out. As you see here is one of my peers, Dr. Van Rushing, and it was really interesting. He's in Memphis, large practice, like 40 primary care docs, huge practice. Great guy, very knowledgeable. And I had told him about this, and I said, you want to give it a try. And he calls me the morning they set it up. And John, I think I called you on this. And he goes, "This was the easiest thing I've ever seen. This is great." And Matt, I had looked back, and for every 10 patients I would send, I'd get tests back on about 3 of them, and the other 7 didn't go. So now I don't have to worry about this because of this point of care. So I thought that was a really interesting point that Dr. Van Rushing said. Next slide, please. And my final thing, as important that Dr. Van Rushing likes this, it's important my patients like this, but it's really important that my staff don't have a mutiny and they say, we can do this. Because whenever I come up with what they say are my crazy new ideas, although I don't think this was too crazy, they're going to say, how much work is this going to do for us? And you see here the first quote from Elizabeth Zwick. She's my lead PA. And she said, again, she's a little skeptical at first when I came up with this. And she goes, this is like a vital sign. This was actually faster than me doing the vital signs, which is really, really easy. And my lead nurse, Jen, said she looked at this. She was the one who wanted me to throw away the handheld camera. She goes, this is just a no-brainer for us to use this. So she was very happy with that. And the final quote I'll give you is from one of the other practices. I piloted this out in Milwaukee and just said, this is just the easiest thing in the world, and we love this. So that was a nice thing for them to say. So, having said that, the experience has been good, actually excellent. I feel like I'm getting it's useful in the office. Again, we've talked about the quickness, the efficiency of it. My nurses are okay. It doesn't take a lot of space. The reimbursement justifies it. But most importantly is I'm getting those screenings up and I'm protecting patients when that protection needs to happen. With that being said, John, why don't we go to the next slide, which starts our Q&A.
Yep, and we have another poll question, Garrett.
Oh, all right. Surprise, surprise. Okay, here we go. And John, do you want to pose this question?
Sure. Has your perspective changed about the importance or effectiveness of providing in-office retinal screening at your practice? A, yes. B, no. C, not sure, need more information.
Yeah, and it may be in direct response to this conversation. I know this was very eye-opening for me, no pun intended, but really cool stuff. Yeah, so I'm very, very excited.
Yeah, and as we're talking about this, keep in mind this is the first on a roadmap of other modalities that can be used with the same set of retinal images. We, TopCon as a company, we are open to any AI company out there. that is utilizing retinal imaging or not, to see how we can help them by being their infrastructure, being their pathway to connecting cardiovascular, urology, eye care, neurology, all based upon images from the eye that are detecting or showing potential uh, disease states.
Very cool. Very cool. All right. I think all the results have come in. I'm going to go ahead and share the results here. And I know Dr. Rosenberg, you can probably see this, but John, for your information, we got 75% says yes, 6% that says no, and about 19% says not sure. Need some more information.
Well, we'll provide you with information at the end of this presentation that you can reach out to us, and more than happy to provide any additional information that you all may need. With that, I'll turn it over to see if there are any questions.
Okay, and I'm going to come back on camera as well here. And yeah, we do have a number of questions. By the way, if you do have a question that you want to ask, go ahead and drop that into the question module. There's a place specifically for questions. And by the way, Dr. Rosenberg, we did get at least a couple replies in terms of, have you been checking the chat?
Yeah. Yes. What have you seen? Let me turn that on right now.
Looks like DRS Plus was one that came up, among others. So thank you guys for responding to that. But let's get into the questions here. First question is, with staff time and logistics being at premium these days, how does this exam impact these key resources?
You know, very important question. And my guess is on the patients, on the folks listening, the participants who said not sure, need more data. That was probably the number one thing on their head. Hey, this is a good idea, but I mean, this thing again, it's on a roller, the one we have, and fits in the corner. Right? It's very easy. It doesn't take up a room. You can have multiple use room, and again, less than 2 minutes. And that was huge. I mean, we have a busy place. I have 9 nurses, and my 9 nurses are at any given time are super busy. So if I do something that takes more than a few minutes, I can't do it. From a cost and an efficiency standpoint, and that was one of the parameters we needed to meet. We did. So less than 2 minutes, I think, is really really good, and especially compared to what we were doing with a handheld unit. But what I would tell anybody is this is one of those things like anything. You've got to make sure your staff is comfortable and they can do it. So you try things like this out, and you kind of work with it.
Great. Okay, next question here is, what is the learning curve for the staff involved?
Funny story with that. John, you remember the first day you came out, we were wondering how long it was going to take, and I put my nurses in there before, and I was seeing patients, and I say, about lunchtime, I came in, I said, hey, John, show me how to use this, and my nurses chased me out of the room. And they said, no, we're handling this. Don't get involved. Super easy for us. Keep away. You'll make it more difficult. All right.
Very
So
true.
so unfortunately, they reprimanded me on that. But they all came by and said, this is just so automated. It is easy. So it's the learning curve is very beneficial.
And from my standpoint, because I do get into different offices, one of the most recent offices I was in, within minutes, they were up and running, and the staff didn't need any, after the initial training, they were running through all the steps on how to conduct an exam without any prodding whatsoever. So
Oh, that is so cool. All right, next question here is, if you were going to be referring the patient to eye care anyway, why do this at point of care?
Great question. We deal with that a lot, and I have patients who ask the same question. If I have confirmation that they're going to go, then and they want to do it there, that's fine. But the reality is, remember, there are some papers that say the compliance rate with screening is 15%. There are others say 50%. We know 50% is high. Most people are not doing it. So they may tell, I go to the eye doctor, I see my optometrist, he's my buddy. I want these quality metrics done. We're graded that way. It's important. I mean, now I'm putting on my CMO hat. I am going to make sure, come hell or high water, these things are done. So I am getting it done. I'm making sure. And the reality is, as we looked back on it, this is the only way for us to keep our compliance up. So again, to answer that question, if I have that sheet from their optometrist or their eye doctor in my hand, that's good. If they don't, I'm making sure they do it at that point because we're not going to miss out.
And the other thing to point out was something that Dr. Rosenberg touched on towards the end of his presentation, and that's the cost of chair time with an optometrist or an ophthalmologist, and the expense that's going to be for the patient that may or may not be needed. If and I am a diabetic, you probably heard my alarm go off earlier. If I don't have diabetic retinopathy, but I go to the ophthalmologist and it's a $200 bill minimum. I Number one, it's money I could have probably saved had I had an exam done in Dr. Rosenberg's office. Number two, that's also the eye care professional. While they love their patients, they would much rather be dealing with patients that have disease versus screening, if that makes sense.
And I would think, just on a personal thought, just hearing you guys talk about this, that part of the reason for doing this too is so that the primary care physician, who is really uh, their personal doctor, would have a more thorough view of their health and uh, be privy to some of this diagnostic information and know for preventative purposes what and how best to instruct them in their own health.
Well, patients really do prefer point of care. And, it's really interesting. If you go through the history of primary care over the years, I mean, all doctors used to be primary care.
Right.
And you would go to the primary care doctor for everything that you do. And then
Pull your
hospitals
teeth
started
too.
specialists. And the problem is, as we fragmented healthcare, you go here for your mammogram and here for your pap smear and here for your prostate exam and here for your lab. We actually do worse than we used to do. And what I've learned over time, and John had he was up here with us. We build a comprehensive center. I think the primary care office of the future, and again, now I'm putting on my CMO cap. The primary care office in the future is going to do the majority of screening and only refer off when we have to, after we found something. So you, as a patient, can say, hey, on this Thursday of this week in this month is my day. I go for my physical in the morning. I see Dr. Rosenberg. Everything gets done, and I'm not seen again by anybody for a year. I get my labs. I get whatever diagnostics I need. I get my eye screened if I need it. We do all of those things because that's the way we actually are going to take care of people, because we are in primary care. We're the captain of the ship, right? The minute they walk out of the office with a referral or a test slip is the minute they start dropping off. And
Mm-hmm.
we're not going to ever get 100%.
Man,
I
that's
like to say you should be the gatekeeper for healthcare. Primary
Right?
care should be the gatekeeper for healthcare.
Yeah, exactly. And for some reason, we got away from that years ago. And I think we are, and I love the concept of the accountable care organizations. I love that Medicare is actually facilitating that. And they're saying, you guys just do it, make sure somebody's doing this, because otherwise it doesn't get done. My dad used to say that he used to call me his pocket doc. He goes, everybody needs a pocket doc, right? And that is somebody who's watching over their care. That's the beauty of what we do in primary care. And this is this is the tool, this is a piece of the puzzle that's completing us. There are a lot of pieces of this puzzle. This is only one of them. But the more that I can do, the more satisfied the patients are going to be, and the more they're going to be, they're going to be getting these things done.
Man, yeah, you couldn't have said that better. I do share your vision, and I think a lot of us who are proponents and of value-based care really agree wholeheartedly. I saw a couple hand applauses come through from some folks in the audience here as we were you were talking. All right, moving along here. Next question is, does this screening provide a diagnosis?
Yes.
It basically, yeah, John, go ahead.
Yeah. I didn't mean to jump in. It's a refer, no refer. So if the patient has referable diabetic retinopathy, it will be notated, and then Dr. Rosenberg's going to refer out to one of his ophthalmologist or eye care professionals.
Great. Next question, just moving right along, and we do have a bunch of questions, and we got some good time here too, so we're in good shape. Does this, and you may have touched on this earlier, does this replace the eye exam done in an eye care provider's office?
It's a piece of the puzzle. So it's the screening that we need for the diabetic, but we still have other things we're looking at. So, for example, if you're an older patient, we're getting a glaucoma screen and things like that. But it gives us you remember the numbers I showed in the beginning. The 15 to 50% of patients get this screen at most. So this is completing that diabetic screen that's necessary because diabetic retinopathies are common, 25%. And if it gets to an end stage, now we're at vision threatening disease. And we want to grow old, and we want to be able to grow old well, and vision is part of that.
And just piggybacking on that, and that's the thing, when you go, 90% of the time when the patients go on to an optometrist or an eye care professional, it's because they're having vision problems. They
Hmm.
can't see, things are getting blurry. One of the issues with diabetic retinopathy is you don't know you have it until it's too late.
Yeah.
And that's why diabetics need to be screened. As we age, I mean, I've been wearing glasses since I'm 45, so 20 some years. Uh, and it's because of my vision starting to go. I have myopathies. I'm presbyopic. Um, but I'm also a diabetic, and if I don't go to the eye doctor, I'm not going to know that I have issues. So that's why it's important that if primary care has the ability to do this testing as a diabetic, my primary care doctor can say, here's all the things that you need to pay attention to, and here's why, go do it. Or I'm doing it here, just like Dr. Rosenberg said.
Yeah, well, as we said in the beginning, screening, and this is when we do research. Screening is important if it changes the trajectory. If it doesn't change the trajectory, it's a waste of time and expensive. If screening this didn't change the vision issue, then I wouldn't be doing it. I'd be waiting till you have visual problems, but we know it does. If we catch the retinopathy early, we can treat it. The outcome is going to be much better than catching it late.
Yeah, very good. Next question here is, let's see, does the report let's see, does the report result positive retinopathy and negative retinopathy? Also, does it include hypertensive retinopathy?
Go ahead, John.
I mean, the exam is for diabetic retinopathy. Um, you know, Doctor, you'd be able to tell a little bit better than I would. Can you tell the difference really between a hypertensive retinopathy and a diabetic retinopathy?
The test result will come back with what we need and to go to the next step. It's going to be normal exam or evidence of more than just mild retinopathy. We need to refer, and that's what we're looking for. So I'm at this point, my guess is at some point, this will be defined more, and I think John did a really good job describing the fact that I think Eric Topol's talk was the eye as the window to the body. And this is one of those things. As this technology is improving, remember this is AI stuff, and we weren't talking about it 2 years ago, you know. But this is what AI is doing, and hopefully these modalities are going to be teaching us a lot more once we look at this part and predict the healthcare of or the health of the patient in the future.
Yeah, and again, piggybacking on that, I thought one of the most interesting but simplest things that Dr. Topol has said in his talks is look at taking images of the retina, the back of the eye. As a human, we'd have a 50-50 shot of saying male or female based upon those eye images. there is an AI out there that's been trained based upon subtle differences that 97% of the time it can tell you accurately, is this a male or is this a female?
Amazing.
So, and that's just basics. So you can see where AI has the potential to move healthcare.
Yeah. And actually that goes into the next question, which you've kind of already alluded to here is can you describe how the AI is used to evaluate the retinal images? And then also, how is the accuracy of the model monitored?
Oh, great question. So, again, I'm not a retina specialist. So the first answer, I'm gonna punt that to John because he is that, and we'll access that. And I kind of wish our software people were on the, or your software people were on right now. But in terms of this, in terms of the accuracy, remember this had to go through the FDA. The FDA had to look at this compared. How does this work compared to a ophthalmologist looking in the eye and somebody trained, and it did really well. So the accuracy is going to be there within the limits that are certainly acceptable, more than acceptable. They're going to be very good. Honestly, and this is just anecdotal, so please don't take it any other way. But I had a patient who had the prior year had a normal exam with us, had a retinopathy, went to the ophthalmologist and said, you know what, you guys picked it up. You know, because
Wow.
remember, I mean, it was the ophthalmologist, great ophthalmologist, and he called me up. He said, "This is pretty good stuff," because remember, the computer, for the most part, computer is not emotional. Not looking at it, there's no subjectivity with that. It's just looking at the whole thing, which is more than probably the human can do.
Yeah, and as far as the AI itself, the AI was trained on tens or even hundreds of thousands of images, looking at healthy eyes, diseased eyes, taught to know the difference between the two. And again, this is, I had said earlier, this is the only solution out there that's been approved for to be utilized both on a desktop or on a handheld. The sensitivity on the desktop is 93%. So in other words, it's the ability to detect that disease 93% of the time, and this specificity was 91%. So here we've got high sensitivity, high specificity, so we know we're capturing true positives with minimal false positives.
Very good. Very good. All right. Next question. We got time for a couple more here. Is do you put one of these devices at each site, or do you share the device with other sites?
That's logistically a really good question. Preferably, I think that if economics have to work here, but and John can answer the economics part, or maybe you can do that another time. But realistically, you want one in each site because of point of care. It's like having a blood pressure cuff in every site. You're not going to ship them out for that. But that all comes down to economics. So, and that's one of the things that I'm with my company as a CMO, again, I have to work through that. Is it going to be affordable for most? And the reality is, if you see one patient a day, that's going to be different than if you're a clinic seeing 200 patients a day. That will help you with your economies of scale with that. But preferably, every doctor will have a tool. Be able to have this in the office, and I think in the future, my guess is this will become more and more affordable.
That
I
when
like how
you couple that,
John.
I was sorry about that. I was going to say that when you couple that with there are, it's our belief, and we've invested in partners who are working on AIs for other disease states. It's our belief that you're going to be able to take that one set of images and be able to screen for cardiovascular disease, Parkinson's, or other neurological diseases, diabetic retinopathy. You'll be able to get a bio age, how your cellular structure is compared to your actual biological age. So there's a lot of different things that are coming where it does not make sense to have a unit shared among multiple offices, because when you've got that diabetic in the exam room or that cardiac patient in the exam room, that's the best time to get the test done.
Absolutely.
I,
It's really interesting. We're almost going to a Jetsons type world where we're going to be able to put our finger into something and it's going to tell us everything about our health. But that's, you know, um, you know, I'll tell you, the excitement in medicine with the onset, the beginning of AI and what it can do for us is just, I think, is fascinating. It's a wonderful time to be a physician and to watch this stuff and be part of it.
oh man, we certainly are in the Jetson era. I feel like already. I'm excited to see even what the next 2 3 years. I mean, it's moving so fast. The advancements are going to bring. Uh, one last question here. And by the way, I got the chance to watch John at one of these conferences do a demo of one of the other exhibitors there and took cellular age and it gave the results. And he said, well, that makes sense with how I've been living the last few years. Uh, but no, it wasn't John. It was one of the other guys that took the result. But it's a really, really neat, and it's very quick in terms of actually producing results. You don't have to wait weeks and weeks, or even days in order to get those results. It comes back with it pretty quick. The last question here is, and this is kind of more logistical, is the machine for lease or for purchase?
We can we will talk to whoever that person is if you can flag that, and we will get
Sure.
them in touch with a solution sales manager. We have a couple of different ways models that we can work with, and more than happy to talk about that offline.
Yeah, I'm sure that's a question that a lot of you guys out there have, and there's certainly more to be learned here. This is the tip of the iceberg with all this. With that, we're going to go ahead and close out. Again, we do have a bunch of more questions that we weren't able to get to, but don't worry, someone's going to reach out and answer your question via email afterwards. So I wanted to thank you, Dr. Rosenberg. Thank you, John, so much for fantastic. I mean, really interesting, great presentations. Such cool stuff. As we close, I'd like to encourage you all to head over to vbcexhibithall.com and check out the TopCon Healthcare virtual exhibit booth. And you can kind of see a demo of what this looks like on the screen. But it's really neat, and there's a lot of great resources there. You can read up on what they're doing, get more information about the screening that we talked about today, and also, of course, interact with them if you would like to. And then finally, if you would like to reach out to the TopCon team, or to John or even to Dr. Rosenberg directly, feel free to do so. Their information is here on the screen for you. And so, or feel free to reach out to me as well. I'm happy to facilitate an introduction if that is easier for you. But thank you all so much for joining us, spending your afternoon with us. Thank you again, guys, for a fantastic presentation, and we will see you on the next one. So have a great rest of your day.
Thank you. Thanks, Dr. Rosenberg. Thanks, Garrett.
Garrett, thank you.
All right. Bye, guys.